Good afternoon and namaste everyone. On behalf of our organizing team of 11th International Patient Safety Conference, I welcome everyone in this pre-conference webinar series. This is the event, the conference, 11th Patient Safety Conference, and its activity is very much awaited by everyone. So we are presenting this conference and hosting on 23rd and 24th at Hotel Sheraton Grand in Bangalore. So like every year, we will also be hosting a lot of pre-conference activities in terms of a lot of webinars, workshops, which would be happening and starting from today. So here we are meeting for our first webinar on a topic which is very near and dear to everyone. Before we go into our today's webinar, let me just give you some background of the conference and this webinar series. As you all know, the IPSC is a very well-known patient safety event in our country and abroad as well. Apollo Group has been hosting this event since last couple of years, and now in our 11th edition, we are hosting this conference on 23rd and 24th February after 10 days in Hotel Sheraton Grand at Bangalore. Before this conference, we will also have 4 workshops on 21st and 22nd of February in Bangalore. And one of the workshops is also being hosted at IIM Bangalore in participation with them. So please do not miss any opportunity. Go to our conference website. Please write to us. Please call on WhatsApp and register for this conference. We have a lot of activities in our conference in terms of patient safety papers, posters, International Patient Safety Awards. There are a lot of sponsors and exhibitors who will be presenting their innovative products into the conference. A lot of learning and networking that you will get. So please register on this website and let's meet on 23rd, 24th of February in Bangalore. We will also be starting our pre-conference webinar series from today, and every day from 3 to 4, we will have specially crafted webinars for all of you, and we will have a lot of eminent speakers who will be talking on various subjects and domains of patient safety. So today we have a topic: redefining patient safety through tools, techniques, and technology. We as a quality professional, we use a lot of tools and techniques and also the technology to circumvent our patient safety issues and to do our quality improvement projects. But let's look at what is new, right? What is the trending? What is the modern thing into our patient safety tools and techniques and technology? To discuss this, we have 2 eminent speakers today. We have Dr. Sunil and we have Dr. Enna. They both will speak one by one. So to start with, let me introduce Dr. Sunil, though he doesn't need much of introduction because we all know Dr. Sunil and Dr. Enna. But formally, Dr. Sunil is the eminent pediatrician, professor of pediatrics at Kasturba Medical College and Hospital, Manipal, who was also the quality management representative for ISO 9001 and accreditation coordinator for NABH for KMC Manipal. And right now he is the quality advisor for Manipal Group and covering a lot of hospitals. He also serves as lead assessor for ISO 9001 and 14001, and is also principal assessor for national as well as international program for NABH as well as ACHSI, that is Australian Council of Health Standards. So he'll be starting a presentation on redefining patient safety tools and techniques. And this will be followed by Dr. Enna. Just to maintain the flow of the webinar, we will take all the questions and answers late. By default, we have put you on mute. If you have any questions or query, just put this on our chat box and we will address this appropriately to one of the speakers. So with this small introduction, let me once again welcome and invite Dr. Sunil to do his presentation. Dr. Sunil, please.
Yeah, Dr. Sanjay. Thank you very much for that introduction. Am I audible? There are many people who have commented that they are not audible. They're not hearing what you are discussing.
Yes, you are audible, Dr. Sunil.
So hope all those things have been corrected. Am I audible now? Am I clear? My voice needs any increase in volume or anything? Okay, fine. Let me share my screen. Is the screen visible?
Yes.
Yeah. Thank you so much. Thank you, Team Apollo, for giving an opportunity to be a part of this webinar. In the bargain, thank you for making me learn also. So the topic given to me was redefining patient safety tools, techniques, and technology, and I'm happy and lucky to be talking just before Anna Madam because I know how good the speaker she is. So let me start. Most of my talk will be concentrating on tools and techniques, and Madam will be covering on technological aspects of it. So when I was going through this patient safety tools and techniques, of course, we are aware of various techniques, both basic and advanced techniques in the patient safety aspects. And since it is a redefining and revisiting these patient safety tools and techniques, I thought I'll be concentrating on only 9 of these patient safety tools and techniques, which are well known, which are gold standards in the assessment of quality of any healthcare setup for that matter. So with that quick background, let's move on to the business properly. First of these techniques or tools which are useful for the patient safety is a daily huddle. Many of you may be aware of it. A huddle is a short briefing or meeting for 10 minutes or less involving care team members usually held at the start of each workday or shift. So most often we do it knowingly or unknowingly, and it's given a name daily huddle. It gives teams a way to focus on care coordination, identify potential or existing safety issues, and flag concerns. It's slightly different from the daily handover or takeovers for the simple reason that it will be concentrating on a potential or existing safety issues on that day or on that time. It provides the opportunity for team members to look back and review the previous day's work and to look ahead to flag safety issues and other concerns for patients for that day. For example, if some safety concerns were there on the previous day, that will be highlighted during this daily huddle. For example, there was a lookalike sound-alike near miss drug administration that will be highlighted during the daily huddle so that the same mistake or the same incident or same event doesn't occur the next day also. It's an effective and efficient way for healthcare teams to review performance, share information, and enhance team communication. And it supports your information exchange. It focuses on patient safety and quality performance. Of course, it doesn't talk about what sari you wear or what dress you wear or what tie you wear on the previous day. It focuses only on patient safety and quality performance. So it actually should be called daily huddle of quality. It engages teams to review standard work such as checklists, update specific quality and safety initiatives that affect daily work, and identify issues that need escalation. It helps to build a culture of safety and teamwork among healthcare professionals and significantly huddles help nurses prioritize patient care and manage patient safety proactively. Especially, let's say there are 30 patients and the nurses have to take care of it, and one patient is on ICD or one patient is having unstable angina. So how are you going to manage or what prioritization you are going to give for these patients in your arena of patients? That is taken care of during the daily huddle. A very, very useful quality tool for day-to-day activities in the hospitals. Of course, yes, bar, all of you know the communication technique of SBAR, that is situation, background, assessment, recommendation, the acronym stands for. Is an easy to use structured form of communication technique that enables information to be transferred accurately between the care teams. It reduces the risk of miscommunication, promotes a common framework for sharing information. The SPAR techniques always helps the person who is transferring the information to cover all the information and not to cover what is unnecessary. It helps prevent breakdowns in verbal and written communications during patient handovers, critical exchange of information, situations requiring escalation and incident reporting. So very, very important. It helps prevent breakdowns in verbal and written communications. It prevents during patient handovers, critical exchange of information and situations requiring escalation or incident reporting. It improves the effectiveness in communication across different disciplines and between different levels of staff by building a common language. SBAR technique may not be a structured communication technique in most of the communications because it's not structured properly. Most often it's used in the nurse to nurse or shift to shift transfer communication. However, the same can be used for communication between the doctors and nurses, doctors when you give the references or cross consultations, or if it's a communication between the doctor, the housekeeping, or the nurse and housekeeping, or the nurse and lab, or lab and ward, or housekeeping, radiology, or ward, or imaging, or any kind of communications, you can use this bar technique where it will facilitate a complete transfer of information. It encourages staff to think and convey information clearly and avoid being vague in information, and it makes a quicker and effective handovers. More importantly, it prevents unnecessary communications. The SBAR, as I've already told you, stands for Situation, Background, Assessment, and Recommendation. Situation is a brief and concise statement that describes the current situation or the reason for the communication. Background is a section provides contextual and relevant information about the patient's medical history, status, or relevant background information. Why are you transmitting or transcribing these informations? Assessment is the analysis or evaluation of the healthcare provider's assessment of the patient's current condition. And recommendation, this section includes the specific actions or interventions suggested based on the assessment. For example, if I'm a pediatrician and I'm referring a case to the pediatric ENT specialist, so I will write down why I'm referring. That is the situation. Background, I'll write a brief history about the patient who is having a recurrent respiratory tract infections and is having earache, would like to rule out any ear infection. The assessment, I will say probably I'm suspecting Eastern catheter or otitis media. Please take care of the situation. And the recommendation, please do a thorough ENT examination. May require an X-ray or X-ray lateral neck or CT scan to rule out a osteometal complex disease. So that is why I am referring this child to a ENT surgeon. So the SBAR technique is a very useful technique that can be used in any kind of communication in the hospital, even forget about the patient safety, even if it is a communication between administrator to administrator. This technique can be used, which can help you in complete transmission of your information to the receiver. Ask me 3, another new technique of facilitating the communication involving the patients. It's a patient engagement, what we talk about. Clear communication between healthcare providers and patients, caregivers, is important for keeping patients healthy and safe. Ask Me 3 is an educational program to educate patients and families to ask 3 questions of their care providers. Please note that it's Ask Me 3. They are allowed to ask 3 questions on any of the aspects. The simple questions are designed to help the patient and families better understand their health conditions and what they need to do to stay healthy. The concept is simple. Asking questions empowers patients. The 3 questions that patients should ask each time they have an appointment or hospitalization are: What is my main problem? What do I need to do? Why is it important for me to do this? I repeat, what is my main problem? What do I need to do? And why is it important for me to do this? If you actually see the communication that happens with the doctors at the hospital or patients and the hospital or the doctors or the nurses is not of these three questions. Most often they ask, what is the cost? Whether Ayushman code is available and why this happened. For all these three reasons, the answers are different, but it will not help in the management of the patients. And it will not help in transfer of communication regarding the patient's condition to the patient bystanders. So patients are sometimes reluctant or unaware to ask questions. There may be a lot of language barriers. They may be reluctant because of the physical barrier. They may be reluctant for the language barrier. They may be reluctant for the socio-cultural barriers. So this Ask Me 3 is a very useful tool in the quality and communication to promote them to ask questions. By creating an environment where questions are encouraged, patients are more likely to be active participants in their healthcare, make less mistakes, and have positive outcomes and increase in patient satisfaction. This is the advantage of asking these questions to the clinicians by the patients. I told you there will be active participation there, healthcare. So it helps in decision making. To make less mistakes so that everybody is clear of what they need to do. Have positive outcomes definitely and increases the patient satisfaction. And it definitely, all these 4 points will help in better patient care management. Healthcare providers should engage patients and families in discussing these questions. So ask them, promote them, encourage them, educate them, and create awareness in the hospital to Ask Me 3 and get these answers to them so that they are comfortable with what the patient's going through. 4, the most common technique that is used in the quality circles is a 5 why analysis. 5 whys. I'm clear it's not 5 wives, it's a 5 whys. 5 whys is a problem-solving technique that originated from the Toyota production system and is often used in quality management and process improvement. The goal of the technique is to identify the root cause of a problem by asking why repeatedly until the underlying cause is revealed. That means to say you don't have an answer for 5 why. Sometimes it's called 3 why analysis, sometimes it's called 5 analysis, 5 why analysis. Whatever it is, when you don't know, when you are stuck without any answer for at least 3 or 5 whys, that is called 5 why analysis, that will be the root cause. If you address that root cause, your deficiency or deviation is prevented from recurrence. The 5 whys technique encourages a systematic and thorough analysis of a problem, helping teams to move beyond addressing symptoms and focus on addressing the root causes. It promotes a more proactive and preventive approach to problem solving. It's important to know that the number of whys may vary depending on the complexity of the problem. Sometimes there may not be N to Y. However, to what extent hospital has contributed, that you need to stop it. Otherwise, it will go on and there may not be end to these 5 why. That is one drawback or challenge with these 5 whys. So it will help to identify the problem, reach the root cause, and when you address the root cause, it prevents a recurrence and it will suggest implement or solutions. The 5 whys technique is a simple yet powerful tool for problem solving, and it encourages a deeper understanding of issues and promotes a proactive approach to addressing the fundamental causes of problems. And it's a very, very useful tool. Most often, most of the quality professionals use this 5 why technique. And when the reasons are more, when the 5 whys reasons are more, then we adopt usually the Ishikawa diagram or cause and effect diagram on the fishbone. The classical fishbone, most of you know, helps your team to work through the possible underlying contributing factors of a problem and sort the factors into a few categories. Especially when you have a Swiss cheese problem, many problems became together to cause a deficient or deviation incident, then you or we adopt this Ishikawa diagram or cause and effect diagrams. The analysis enables your team to create insights into the problem and start to consider possible improvements or solutions. Fishbone diagram is a commonly used root cause analysis tool to determine why a particular problem is occurring. It helps you to identify a wide range of possible contributing factors, not just the obvious most. And more importantly, you can use Ishikawa charts or cause effect programs to find out the checkpoints. For example, if there is a procedure to be done, for example, lumbar puncture to be done, so you need to know clearly, and if there's a deviation, let's say the patient's sample was not sent for biochemical analysis for some reasons. So you do root cause analysis and found that there are many other issues like man, material, etc. And you can have checkpoints. Without these, you are not supposed to send the lab report. Or does this responsibility should be completed before you go to the next responsibility. Ishikawa diagram is a tool graphically displays the relationship of the causes to the effect or outcome, and it can also be used in identifying areas for improvement. Its causes are typically grouped under 6 categories, mostly manpower, methods, material, machine, measurement, and more other nature. Or 7 categories of contributing factors like patient factor, individual or staff factor, team factor, work and care environment factor, organizational factor, task and technology factor, and external factor. So when you identify where exactly the problem is and what is the role of these responsible, who are the role or who has to take these responsibilities in preventing this recurrence, that your fishbone or cause effect diagram is successful. The 6th tool which I would like to mention is the FMEA analysis, failure mode and effect analysis. It's a technique for conducting a systematic analysis of process or products to identify and prevent any problems before they occur. We see, we sometimes we define the quality as do the process correct all the time, even at the first time. So it prompts your team to proactively review and evaluate what could go wrong. Failure mode, why failures happen, the causes, and the consequence of failure, the failure effect. That's why it's called failure mode and effective analysis. So I repeat, it prompts your team to proactively review and evaluate what could go wrong, failure mode, why failures happen, and the consequence of failures. Improvement plans can then be carried out to prevent the failures in your process. FMA is particularly useful in evaluating a new process prior to its implementation and in assessing and managing the impact of the proposed change to existing processes. And healthcare organizations should apply FMEA to assess new services and procedures before implementing team. You see the latest accreditation standards as well as quality management system, that is ISO. It mainly deals with the risk analysis and risk-based assessments, so that you proactively think about the risk and its impact on the organization and minimize the risk even before it occurs. That's what earlier we used to call as preventive action. 7th one is the action hierarchy. A critical step in the RCA process is the identification and implementation of actions to address system vulnerabilities that have been identified. A critical step in the root cause analysis process is the identification and implementation actions to address system vulnerabilities that have been identified. That's called action hierarchy. Investigation team should design actions to prevent incidents from recurring. If that is not possible, reduce the probability and severity of harm to the patient should stop. Studies have shown that the lack of emphasis on actions is one of the main reasons for root cause analysis and not yielding the desired results. For example, when we go with assessments, we see that corrective action, preventive action have been suggested and been implemented, but the non-conformances still remain the same. There is no improvement. So this is where we fail, because we do not emphasize on actions that needs to be taken, that is corrective actions and preventive action. Action hierarchy is a tool that will assist investigation teams in identifying stronger actions that provide effective and sustained system improvement. It is recommended that investigation teams should identify at least one stronger or intermediate strength action for each root cause analysis. A stronger action is likely to eliminate or greatly reduce the recurrence of event, and intermediate actions may help to control the event identified. The weak actions less likely to be effective when used alone. I'll explain this with an example. Stronger actions are generally less reliant on humans and vice versa. Weaker actions may be important to support stronger actions and can also be used as temporary measures until stronger action can be implemented. Examples of stronger actions are major innovations of a nursing unit to move the nursing station to a more central location for better visibility and accessibility by nurses, staff, and patients' families. I'll give an example of writing prescriptions in capital letters. When we had this initiated, the total compliance was 17%. That means the 83% were non-compliant. In spite of repeated training and repeated orientations to the clinicians, the compliance rate increased to 20%, 25%, 30%. So we need to have stronger actions which are not reliant on humans. So what we did was introduce the e-prescriptions, electronic prescriptions, where the doctors can easily type and they can get the scroll down menu and they can select what they want, and the printout automatically comes as capital letters, in capital letters with the pharmacological names. Now, with the introduction of e-prescriptions, the compliance rate to the extent of, I can say 98 to 99% has been achieved. The stronger action was taken here by the administration to improve the quality, and as a result, we could avoid many illegible handwritings, capital letters, and many such issues related to the medication management. As a result, medication-related errors, prescription-related errors have come down. The last which I'm going to discuss is the Pareto principle. Most of you know the Pareto principle, commonly known as the 20-80 rule, is an important quality tool for safety and process improvement. According to the Pareto principle, in any group of factors that contribute to an overall effect, roughly 80% of the effect comes from 20% of the causes. 80% of the effect comes from 20% of the causes, means if you address these 20% of the causes, where 80% of the problems will be solved. Using a Pareto chart helps your team to prioritize and focus on patient safety interventions that have the greatest impact, thus saving effort and cost. This tool enables the team to make informed decisions and concentrate on the vital few, the factors that have the largest contribution to the effect, and also provides a rationale for not taking actions on the useful many factors that have a relatively smaller contribution to the effect. So you can ignore those 80% of the causes, because if you address this 20% of the causes, you can address 80% of the problems. Classical example given is the discharge summaries, where the delay in the discharge summary is because of, you find out the cause, and most of the reasons are because of the 20% causes, which initially do happen during preparation of the discharge summary. So you address this causes, automatically the turnaround time for the discharge summary will come. Sorry, I think I have covered already. Yeah. A Pareto chart is mainly used in the phase of problem identification. It presents the data in a visual manner and helps your team to communicate the problem or situations to senior management and seek their support or actions. Pareto chart is in the bar chart format, in which the various factors that contribute to an overall effect are arranged in order from the largest to the smallest contribution to the effect. And as a result, let's say if you address these 4 or 5 causes for the deviation, you'll be covering the 80% of the problems. That's what's called Pareto principle. I think I missed this flow chart. A few words of the flow chart, known as the process map. Flow chart is a visual representation of the sequence of steps in a process. Having a clear understanding of your current process and how it works is an important first step in identifying and developing implementation plans. The visual representation of current process helps teams to better focus to identify problems to bottlenecks. Steps that do not add value, causing breakdowns in communication or are unnecessary, can become more apparent when viewing in a flow chart. Such analysis can be the basis for implementing improvement plans. The classical flow chart or the process map, we do it for many processes, and that will help us to identify the bottlenecks, and that will help us to improve. The flowcharts can help to find one or multiple sources of a problem or examine the handoff that occurs in a process. At times, it is being used to identify personnel, group, or entire departments that are responsible for the process of tasks. To create a flowchart, your team will brainstorm all the steps in the current process. Each process step is written in a box In addition to the steps themselves, use a diamond shape to indicate points in the process where a decision needs to be made. For decision steps, your team writes a yes or no question, then use lines to show the connections between the boxes and diagrams. A classical example we give is, for example, when we had the compliance rate of blood transfusion consent form to the extent of 20 to 30%. We did the flowchart analysis and found out that it is at the blood bank level, the things are not happening. So what we did is we empowered the blood bank officers not to issue the blood unless the transfusion request is associated or is comes to the blood bank with a filled consent form. If the consent form is not properly filled, it will not be honored by the blood bank. And as a result, there was a checkpoint, there was a bottleneck, and that bottleneck has been clearly solved. Now the compliance to the extent of 99%. So these are some of the easy ways or quick, good, and time-tested quality tools and techniques. These are the essential patient safety tools and techniques which are indispensable in healthcare, and they can help you in identifying root causes, minimizing errors, and improving the overall quality of the patient care. They can also bring sustained improvement by fostering a culture of safety and teamwork, enhancing communication, and proactively preventing many of the failures. This again is a Pareto principle, 80 to 20 principle. That means to say, if you address these 9 techniques, most of your problems will get solved in your hospital as far as the safety and errors are concerned. So with that, I conclude. Thank you for your patient hearing. We'll be definitely happy to answer your questions at the end of the second session. Over to Dr. Sanjay.
Thank you so much, Dr. Sunil. Huddle meeting, S bar, 5 whys, ask me 3. Very simple but very effective tools that we generally use in our day in, day out operational activities, quality and patient safety activities. And as you said, it's all time tested. They have been very effective, very efficient, and I think we all have been using this kind of tools in our activities. So thank you so much for alluding on this particular thing.
Thank you, Sanjay.
But the picture is not yet over. We have Dr. Enna, who will be talking more on the technology part of patient safety tools and techniques. Before I invite Dr. Enna, just a couple of words about Dr. Enna. Again, she's very famous and very prominent personality in healthcare quality and patient safety domain. She is head of quality at Esther India, and she is keeping an oversight on quality as well as clinical excellence program across 18 units of Esther India. Before she joined Esther, she also worked at Rajagiri Hospital as VP Quality, Medical Trust Hospital, and Lakeshore Hospital in Kochi, and taking these hospitals through JCI, NMBH, and so many other accreditations and recalculations. She was also once deputed to Mauritius from the Rajagiri Hospital, and she spent around 1.5 years, to lead a project, executing turnaround leadership and change management as a CEO of that hospital there. Dentist, by qualification, she also has done MHA from Osmania, Hyderabad, PG DMLE from National Law School, University of India, Six Sigma Green Belt certification from Exemplar Global, and also a strategic management certification from XLRI, Jamshedpur. She's also CPQIH qualified from CAHO and faculty as well as secretary to CQE wing of CAHO, and a trained assessor of NMBH as well as ACHSI. Not only that, she's also pursuing her doctorate from TIS, Tata Institute of Social Science from Mumbai, in area of healthcare management. Dr. Anna, please.
Thank you. Thank you so much, Dr. Sanjay. It's always nice to associate with you, with Gaurav, with the Apollo group. It's always a privilege and honor for us when you invite us, to be a speaker. And as always, Apollo does wonderful work. Even the conferences that you organize are, excellent. We look up to you to how, to actually organize conferences. So my duty today is to speak on patient safety with regarding to technology. So Dr. Sunil had given excellent points on, how to use tools and techniques. And I'm just going to add on how we can use technology also to improve on patient safety. So I'm just taking a minute. And warm good afternoon to everybody who decided to join and listen to us. So I hope you can see my screen right now.
Yes, it is visible.
Yes. Moving on. So we all talk about quality management system. We're all people who are, focusing on quality, patient safety. And we know that there are so many different things when we talk about quality and patient safety. And it is really synonymous because quality also means freedom from defects, which is also basically coming to doing no harm when it comes to a service industry like ours. Now, when we look at this big diagram, which is basically put for an aesthetic purpose, but there are some points with regarding to design control, risk management, very important points, risk review, eliminate non-conformities, look into risk monitoring, vigilance. These are all terms that are very, very synonymously and very commonly used when it comes to our entire quality management system. Now, this is something that all of you are familiar with. First, do no harm. It's part of the Hippocratic Oath. And this is the main thing that as medical professionals, nursing professionals, or people like us who are working in healthcare, the prime intent is to ensure we do no harm. So patient safety first. Now, these are some hard facts, some things that, most of you are familiar with. Just go through them again to refresh our memories. Approximately 400,000 hospitalized patients experience some type of preventable harm during their hospital stay. Depending on the studies, medical errors can account for over 4 billion per year, the cost of quality or cost of lack of quality. Medical errors cost approximately 20 billion a year. Medical errors result in about 100,000 people dying, and medical errors typically include surgical, diagnostic, medication, devices, equipment-related, system failures, infections, falls. All these attribute to patient harm. A lot of malpractice claims in hospitals are related to surgical errors, also related to missed or late diagnosis. Slightly more than half of the paid malpractice claims are related to outpatient care. To decrease overheads, hospitals do reduce staff, particularly nursing staff, and this also can relate to patient harm. Moving on to what are the common errors in healthcare. Medication errors tops the list, right? That's something that all of us, you, me, we all monitor very closely. And when we talk about medication errors, we talk about prescription, transcription, dispensing, administration, monitoring errors. Surgical errors, again, something that we are very familiar with, and one of the international patient safety goals of surgical safety checklist focuses on preventing wrong patient, wrong procedure, wrong site surgeries. So surgical errors also do happen. Missed or delayed diagnosis, something that is interconnected to a lot of things. It's not only the clinician's competence, but there could be diagnostic issues, there could be diagnostic errors happening, a lot of interconnected, lack of communication, lot of interconnected things. Patient misidentification. So we come back to the International Patient Safety Goal number 1, where patients need to be identified correctly at every point of care. It is every point that requires that patient identification. Transfusion errors, and that could be really fatal. Pressure ulcers, something again that we monitor very closely, and where the Braden scale that is used for the skin assessment, all those things are done to identify risk and prevent. Antimicrobial usage and associated errors, which is the buzzword and discussed in all forums, the antimicrobial stewardship program, errors in terms of giving a high level or a high dose of antibiotics when you don't need to. Hospital-acquired infections and sepsis, something very common and something which is tolerated in our country, which shouldn't be ideally. Orders missed or duplicated happens, and diagnostic errors, sampling errors, reporting errors, unsafe injection or infusion practices. These are some of the common errors we come across. Now, the reasons of errors can be errors of omission or errors of commission. Omission meaning I'm supposed to do something, but I did not do it, right? So that is omitting to do what I'm supposed to do. Commission is something I did caused harm, right? So administering a medication who has a known allergy, is something that has caused harm. Now, coming to technology. Now, technology again is a buzzword, especially in healthcare. Well, everywhere we are covered by gadgets, and we are always hooked on to gadgets. And we find being tech savvy is the in thing now, and that rule goes for everywhere and everything, every industry. Now, when we come to technology, the direction technology innovation in healthcare is moving, it's basically about closing the loop. So what does that mean? It means connecting people, connecting departments, connecting services to ensure that continuity of care. It's also plugging in those gaps or loopholes that we may have, which might create patient harm or which might result in a risk that can lead to a patient harm. One of the most important things in this aspect is basically trying to get the whole picture of the patient on that case record, what we call electronic medical records, making sure that accessibility to the complete information is there. We also have heard about medical alerts or clinical alerts. The fact that there has to be integration or interoperability of different systems, if involved, is also important. And when we come to data, now data analysis tools, analyzing tools is important for us to convert that data into information, information into knowledge, knowledge into wisdom. So it's very important that all the data that we collect, the historic data, the current data, is utilized in some way to improve our knowledge and thereby our wisdom to take informed decisions. The priorities for digital clinical safety can be considered in two parts. First, the intrinsic safety of technologies, and second, the extrinsic ability of technologies to drive safety. So these two components have to be embraced to understand what exactly is the role in digital clinical safety. Now, patients and staff must be equipped and empowered. They have to be equipped and empowered, which means technology has to help you do better, and technology has to make your life easier and not the other way around. Now, there are some principles for digital safety in the sense collaboration, partnerships, people need to be working together. And this is not just about the healthcare professionals. We all know that if we want to get a system implemented in our hospital, how the number of parties that work together for getting that system integrated. It's the IT team, you have the doctors, you have the nurses, you have finance, you have operations, you have procurement, everything is linked. It's very important that at each area, the risks are understood and managed effectively. Openness, it is very important for the staff to mention or voice out what are their concerns when it comes to any process. Iterative change, identifying and learning from events and trying to correct those to make the practices better. Proportionality, the complexity, level of clinical risk. We can't do everything at once. So it is very important to identify and prioritize based on the risk. Inclusion, ensuring there is active cooperation of everybody who is involved in that system. Some of the digital tools that can help. Clinician decision support. Now, this is something that has been talked about a lot, and we do have these resources even now in some of our HIS. Basically, it helps the clinicians to take a decision. It prompts them to take decisions, and they can be based on various algorithms, which are again based on historical data and evidence-based practices. Coming to CPOE, computerized patient order entries. Now, this is something that most of us are already doing. Basically, the orders have to be on the system and not on paper. Now, this, especially when it comes to prescribing medications, it has been proved that when you write in or when you type out into the system, there are chances of reducing prescription errors and transcription errors. Now, what is normally done, or the usual way that we used to work, is when there is a doctor writing it in the orders, and then a nurse or somebody else transcribes it into the system, and this goes as a indent to the pharmacy. If you can eliminate that step and the prescription is directly put into the system and the prescription becomes the indent. We can ensure that there are no multiple people acting on that and, giving rise to certain transcription errors in the process. So there are many incidents that we come across where prescription errors have happened because of this. And to avoid this, if we ensure that all the orders are put directly by the prescriber or directly by the clinician, that element can be resolved. Coming to alerts and alarms. Now, we also know that alerts and alarms are mainly meant for timely prompting the caregiver, which can be the doctor, which can be the nurse, for ensuring that care is given at the right time. For example, critical value elements or drug allergies, alerting, or you have written a dose which is much higher. It's a pediatric patient, and you've given an adult dose. If there is some sort of software that detects this and gives you that alert, or even therapeutic duplication. We talk about medication reconciliation. Is it possible that the system can alert when there is therapeutic duplication because we may not have done the reconciliation properly? So these kind of things can prompt the clinicians as well as the care provider. There is one downside to it also, alarm fatigue, and sometimes the tendency to override alerts. So sometimes an alert is given, but we tend to override it and say, no, my decision is final. So these are all things that can happen in the process. Coming to electronic medical records, again, it's the buzzword today, and we are all fighting a big battle because it's also just not about electronic medical records, it's also about change management. So you're changing age-old behaviors and cultures, trying to get them work on the systems. There are a lot of challenges because it's still an evolving process. There are definitely challenges with regarding software, with regarding hardware, bedside devices being available, the training and the learning curve that's involved. All these things are involved. Patient data management systems, for example, the ICA that the Philips have, the data or the monitoring of the patient using the biomedical devices is directly captured into the HIS. So you don't have to, you can avoid writing and, transcribing again. So these are some things that can also help. It's real-time data. And of course, coming to a quality management system, need for HIS integration, because there's a lot of data we get from a quality perspective or a safety perspective, indicators that we monitor, which we base on manual data capture. There's a lot of information which is directly captured from the HIS, and if the integration is possible and this system is automated, we can also ensure there is real-time reporting, there is real-time data, and there's validated data. So these are some of the tools that can help. Actions to decrease errors in information technology. As I said, everything is good, but there is always a downside. So we have to ensure, that certain processes are also put in place. For example, automating dispensing devices, barcoding, that's already happening everywhere. You just read the barcode and the patient details, everything comes. So there's hardly a chance for making an error. You don't even have to go and read the patient ID, check and all that if you do this barcoding. Computerizing the medication administration record. Again, most of us may have EMR, but the medication record in many places is still handwritten. So we need to move into computerization, computerizing the order entry and decision support, intercepting error messages at the time medications are ordered, prompt warnings, we already discussed that, providing drug-specific information, very important. There are some things to consider, some concerns that we have. Could be a drug-drug interaction, could be a food-drug interaction. This helps. Providing up-to-date information on new drugs. So there are studies that have proved that computerized provider order entry systems could reduce the medical errors. And this is something that we should definitely look into. These are some studies, meta-analysis that has been done to evaluate the effectiveness of computerized patient order entries to reduce medication errors. And it is seen that there has been a significant change. There has been another study which talks about discussing with different groups of healthcare professionals, and it has revealed that areas where technology can help, other than the ones that we already discussed, antimicrobial stewardship, point-of-care testing, microbiology test reporting, and mobile automated dispensing systems. This study basically talks about what more can we do than the all the other points that we discussed. Probably the strengthening of the culture of antimicrobial stewardship, improving on point of care testing, not limited to the few things that we already do, microbiology test reporting and mobile automated dispensing systems will help to improve on patient safety. So these are some of the things that technological advance can do to potentially prevent adverse events, automating tasks, facilitating information sharing, improving on clinical decision making, intercepting potential errors, and reducing variations in practice. We can put clinical pathways, clinical protocols, guidelines, so it guides the clinician in ensuring that evidence-based practices are followed. There are always barriers and limitations. Even something very good can also have some few things that we need to look into. And one of the biggest challenges we have seen is the training period and the learning curve. So we all have to get there, in the sense every software might be different, every technology might be different. So making somebody used to, especially in a healthcare organization where attrition is high, and changes happen more often, this learning curve can affect work or can cause delays in work. Sometimes you get into something and you're stuck somewhere, you don't know where to go. The whole patient experience can get affected because of that. Adequate handwear and handle devices. This is definitely something that can pose a problem. Sometimes we say somewhere where one clinician was required, now we need to have a physician assistant. Now, beyond that, we say, okay, the system is somewhere and the patient is somewhere, it is difficult to enter the notes. So sometimes we have seen even nurses doing duplication. They write in sheets, they go back and enter. Bedside devices are important. Handheld devices are important. Script to text or voice to text devices. All these things can help in trying to make life easier for the end users. Data security and privacy issues, it's a big thing now. I think last August or September, the new Data Privacy Act, it's so important now. We take a consent. We are very careful about who has accessibility to the information. So in a digital world, it's very difficult unless we have the right processes to ensure that the login is restricted, only authenticated and authorized users use. It's very important that we have these security measures so that data privacy and data security is maintained. Alert fatigue, we spoke about it before, and cost. That's a big thing, cost. So sometimes, though in principle we agree, everybody agrees, all this is very nice. When it comes to the cost, again, we need to rethink and prioritize. And that's where we are still stuck at. That is some of the references that I used for this presentation. And that is the end of my presentation. Happy to take questions.
Thank you so much, Dr. Anna. It was so informative, so enriching. A lot of fresh perspectives on digital safety, digital tools, and as you rightly said, nothing would come without limitations or cost or something. So this is how we generally prioritize our processes and digital tools that we employ for our patient safety execution. Thank you so much, and you both have been so timely. So I didn't have to bother about timing and all. Thank you so much, Dr. Sunil and Dr. Anna. Time for a couple of questions. I guess Dr. Sunil has already started answering some of the questions. Let me just scroll up and see if there is something else.
There is one question on Pareto principle. Shall I answer?
Yes, please.
Yeah, it is 80-20 principle or Pareto principle, where you identify the root causes for your repeated problems. Repeated deficiencies, you identify the root causes and find out how many of them are because of the first three or the most recurring three important causes. You address those three causes, over 80% of the problems will get solved, and it will be easy for you to take care of the remaining three, which are not so vital. So take the vital root causes and then address it. Your problems, 80% of your problems get solved. That's called Pareto principle. Hope I have answered your question.
Yes, I think most precisely you have answered, Dr. Sunil. Any other questions, audience? You can just write in the chat box. We still have 2-3 minutes to take at least 1-2 questions. I guess there is none. So thank you so much, Dr. Sunil, Dr. Enna. And I think as a opening webinar, you have been so fabulous and so informative to all of us who has been patiently listening to you since last 1 hour, and it was time worth spent. So thank you so much on behalf of Apollo Hospitals and IPSC conference organizing team. We immensely thank you for your time and contribution today, and we'll see you during the conference.
Thank you. Thank you all.
Thank you, Sanjay.
Good evening.
Yeah.
Thank
Bye.
you. Thank you.
Have a nice day.
As I wrote in the chat box, we also have exciting webinar tomorrow on innovations. So how do we innovate for our modern healthcare environment and making our hospitals as a future-ready hospital? As you all know, the theme of this conference is the future of the patient safety. So we are not thinking about the current times, but we also look at how things could be from futuristic point of view. So in the same context, we would also welcome you tomorrow to register and then listen to the exciting webinar that is going to happen tomorrow at 3 p.m. On the same platform. I also had put up the link for you to register, and also I request you to spread this word as well as this link to all your colleagues and professional contacts so that maximum people can take benefit of these webinars. So thank you so much for joining today in this webinar. And as I said earlier, we have exciting conference coming up on 23rd and 24th of February at Bangalore, Sheraton Hotel in Whitefield. So a lot of papers, posters, award, a lot of exhibitions, and we will also have a special and exclusive exhibition on smart and future-ready hospitals. So how a hospital could be probably after 10 years or 20 years. So we will be happy to show you that glance, and you will also have a lot of opportunity to meet with global speakers and global health leaders who are expert in their own field, who will share a lot of new insights and perspectives on patient safety. So please do not forget to register, and we'll see you in the Bangalore. But before that, we'll see you tomorrow. Please register for the webinar tomorrow. Thank you so much. Thank you. Thank you once again, Dr. Sunil and Dr. Enna. Thank you so much.